Hi physios, welcome back to our channel. In today's topic, we are going to discuss about the principles of intensive care physiotherapy. Core principle number 1, early intervention, prevent secondary complications like atelectasis, contractures, deconditioning, pressure ulcers, etc. Number 2, multi-system support, as work alongside respiratory, cardiac and neuro teams to address the complications of immobility, sedation and mechanical ventilation. Number 3, maintaining the airway patency. Techniques like suctioning, chest physio, positioning and mobilization to aid secretion clearance. Number 4, optimizing ventilation and gas exchange. Encourage lung expansion technique like deep breathing, incentive spirometry, positioning and use CPAP or BiPAP as needed. Number 5, mobilization and early rehabilitation. Even in ventilated patients, passive ROM to assisted ROM, sitting to ambulation with devices. Number 6, close monitoring. Interpret vital signs, ECG, oxygen saturation, ABG values, and adjust interventions accordingly. And also, number 7, patient-specific and safe interventions. Consider medical stability, sedation levels, and equipments before initiating therapy. So this video will be a long, lengthy one as we have divided into segments. The first segment is the principles of ICU physiotherapy, that is intensive care, and ICU equipment and physiotherapy relevance. Number 1, endotracheal tube, that is ETT, inserted via mouth or trachea into the airway for mechanical ventilation. Physio role, suctioning through ETT of the secretions, mobilization without dislodgement, maintaining airway hygiene. Number 2, tracheostomy tube. Number 1 is endotracheal tube. Number 2 is tracheostomy tube, surgically inserted into the trachea through the neck. Long-term airway management. Physiotherapy, suctioning, humidification, chest physio, assisting in weaning process. Number 3, humidifier, adds moisture to dry inspired air, prevents drying of secretions and mucosal damage. Types: heated humidifiers, heat moisture exchangers, that is HME, important in ventilated patients or with the tracheostomy. Number 4, ventilators, provide mechanical ventilation to the patients unable to breathe adequately. Mode: controlled assisted SIMV pressure support. As we have discussed already in previous videos, just you can have a look. It will be available in our channel. Physio focus understanding settings like FiO2, tidal volumes, rate, and also mobilization and suctioning during ventilation. Number 5, high frequency ventilation, HFV, small tidal volumes at high rates, that is 100 to 900 breaths per minute, used in ARDS neonates. So the physio role will be minimal handling, monitor for a barotrauma. Barotrauma is also already discussed in our channel. Please do have a look in the previous videos. Next, 6th one is differential ventilators. Allow independent ventilation of each lung via double lumen tubes, used in unilateral lung pathology. Physio care with positioning, avoid disconnecting circuits. CPAP mask, continuous positive airway pressure mask, non-invasive support to keep alveoli open, often used in sleep apnea, COPD, early pulmonary edema. Physio goal to promote spontaneous breathing and reduce the work of breathing. Number 8, suction pump, remove secretions from airway, can be manual or electrical. Physio role performed via ETT, that is endotracheal tube. As you can always keep on practicing and keep on revising the topics. Performed via ETT or tracheostomy, pre-oxygenated before suction. Monitor for bradycardia, desaturation. 9, ECG, electrocardiogram, monitor heart rhythm and rate. For that, before you have to learn everything about ECG and the patterns. Physio interpretation, tachycardia, bradycardia, arrhythmias. Determine safety for mobilization. Number 10, pressure monitors, measure various internal pressures like atrial, A line, that is atrial line, central venous pressure, CVP line, and also Swan-Ganz, pulmonary wedge pressure. Physiotherapists should avoid dislodging lines and know limits for mobilization. If the line is dislodging, then you have to stop. It's your limitation to mobilize. Intracranial pressure, ICP monitor, monitor brain pressure after TBI, that is traumatic brain injury. Normal ICP is equal to intracranial pressure will be 7 to 15 mmHg. So the physio role: avoid position that increases ICP head down and avoid hyperventilation or vigorous interventions. Temperature monitors: track core body temperature, elevate the temperature, infectious risk, hypothermia, that is decrease in temperature, perfusion issues. Physio adjust intensity based thermoregulation. So these are the 11 physio ICU, that is ICU equipment that physios can relate. Number 1, endotracheal tube. Number 2, tracheostomy. 3, humidifiers and ventilators. 5, high frequency ventilator and differential ventilators. 7, CPAP. 8, suction pump. 9, ECG. 10, pressure monitors. 11, intracranial pressure monitor. 12, temperature monitor. So these are the 12 physio role in ICU setting. Next, physiotherapy assessment in post-operative ICU setting. General clinical assessment parameters. Even though the doctors and the physicians and also each and every specific the multidisciplinary approach in each and every sections, neurologists will take their assessment, psychologists will take their assessment, cardiologists will take their assessment, each and everyone, even OT, occupational therapist also take their assessments. And for the nurse, they'll revise the assessments from each and every multidisciplinary team. As a physio, what are the assessment part we should cover a post-operative ICU setting patient? Number 1, special surgical instructions. Review operative notes and physician orders. If the physician have ordered for something, not to make the patient mobile or the transfers fast from bed to stand or walk, we have to follow that for up to how many months. And if the thermoregulation should have to maintained, then the intensity should be reduced. It should be low and moderate. Review operative notes and physician orders. Movement restrictions, that is sternotomy precautions and drain management protocols. What are the drain? For the postal drain, secretion drain, weight bearing limitations. So if they are done with the endostomy or tracheostomy and they should not carry a weight more than 1 kg, it should be followed. And we have to educate the patient that it should not be done. What happens if they are not obeying? Then the incision, then the sutures. So we have to educate the patient. Use of splints or braces. Respiration rate should be 12 to 20 breaths per minute. Deep and rhythm. Shallow, labored, irregular. Use of accessory muscles: sternocleidomastoid, scalenes, pectoralis, major and minor, etc. Presence of dyspnea or hair hunger. Type of support: spontaneous, CPAP, BiPAP, ventilator. Level of consciousness: using Glasgow Coma Scale. For scoring, observe alertness, response to verbal pain or stimulus, signs of sedation, agitation. Skin color: pale, anemia, poor perfusion. Cyanosis, hypoxia. Flushed, infection, fever. Jaundice, hepatic dysfunction. Vital signs monitoring: parameter normal range, clinical notes. If the BP is 100 to 140 or 60 to 90 mmHg, hypotension in shock, hypertension post-OP. Pulse 60 to 100 BPM, tachycardia and pain, fever, fluid loss. Temperature is 36.5 to 37.5, fever may indicate infection. Sputum analysis. So the color, if it's clear, it's normal. If it's yellow or green, infectious. Blood strain, hemoptysis. Quantity: minimum moderate, copious. Consistency: thick, frothy, tenacious. Ease of expectoration: spontaneous versus suction required. Analgesics: drug administered. Record last dose of analgesics, sedatives, antibiotics. In order to that, we can give the exercise protocol. Important for timing physiotherapy safely. Monitor for side effects: drowsiness, nausea, hypotension. Presence of drains type: chest drain, abdominal drain, wound drain. Check the site of insertion, amount and the color of drainage, securing and patency. Physio caution: do not dislodge or consider during mobilization. Presence of special devices: pacemaker. No pacing mode, demand versus fixed. Avoid electromagnetic interference. Intra-aortic balloon pumps, IABP. Assess cardiac output. Strict positioning, usually supine. No hip flexion if it's less than 30 degree. ECG monitoring. Check for arrhythmias, AF, VT, PVCs, ST changes, ischemia, heart rate, rhythm regularity, and review the baseline versus current tracing, atrial blood gas analysis, ABG parameter, normal value, clinical interpretation, pH, PaO2, PaCO2, HCO3 minus, that is bicarbonate, SpO2. If the pH is 7.35 to 7.45, it is acidosis or alkylosis. PaO2 80 to 100 mmHg decreased in hypoxia pulmonary dysfunction. 35 to 45 mmHg increased in hyperventilation. 22 to 26 MEq by L metabolic compensation. 95 to 100 percentage is less than 90 degree clinical concern. Size of heart via chest X-ray or echocardiogram. Cardiomegaly may indicate heart failure, pericardial effusion, physio implications like caution with fluid overload or low tolerance. Presence of secretions. Listen to the breath sounds, crackles, fluid, bronchitic secretions. Observe cough effectiveness. Placement of the chest tube. Identify location, apical air or basal fluid, patency and securement, suction or underwall seal. Physio considerations. Mobilize without kinking below chest level. Observe for the air leaks or excessive drainage. So let's have the summary checklist for ICU physio assessment. Surgery detail, respiration, consciousness, color and vitals, sputum and cough, drugs, drains and tubes, pacemaker and or IABP, ECG, ABG, test tubes. So next topic is physiotherapy after pulmonary surgery. Pre-operative phase, that is a treatment technique. Number 1, patient education and explanation. Goal is to reduce anxiety, improve cooperation, post-surgery, set expectations and improve compliance. Instruction include nature of the surgery, importance of the chest physiotherapy, post-OP pain management and mobility goals, role of breathing and coughing exercises in recovery. Care of incision. Teach splinting the incision while coughing or moving. Use a pillow to reduce pain and protect the wound. Avoid excessive strain on the surgical site. Proper posture to prevent pulling on the incision. So first one is patient education and explanation. Number 2 is care of incision. Number 3, mechanical ventilation awareness if anticipated. Educate on endotracheal tube or tracheostomy. Inability to talk temporarily while intubated. Importance of early mobilization and physiotherapy even when ventilated. Number 4, breathing exercise technique. Diaphragmatic breathing, segmental breathing, pursed lip breathing. If it's diaphragmatic, place hands on the abdomen. Inhale slowly through the nose and expand abdomen. Segmental breathing, place hands on lower limbs or lateral chest to direct expansion. Pursed lip breathing, inhale through nose, exhale through pursed lip. Aim is to improve lung expansion. Prevent post-OP atelectasis and pneumonia. Huffing and coughing technique. Huffing, forced expiratory technique, FAT, is called as huffing. Inhale deeply, forcefully, open mouth, exhalation like fogging a mirror. Less painful, more energy efficient than coughing. Coughing, teach splinter cough like using a pillow. Educate on controlled staged cough to clear secretions. Number 6, mobilizing exercises, passive and active ROM exercise for upper and lower limb to maintain circulation and joint mobility. Reduce the risk of DVT and stiffness. Bed mobility, rolling, bridging, sitting on edge of the bed. Chest mobility exercises, arm elevation with inhalation, trunk rotation and side flexion with deep breathing. Number 7, posture correction. Teach erect sitting and standing postures. Avoid slouched posture post-OP to prevent secretion retention, reduce the lung volume. Incisional discomfort. Number 8, graduated exercise program. Levels, pre-OP conditioning based on patient tolerance, breathing with movements exercise, example shoulder shrug with inhalation, marching in place, stair climbing practice if applicable. Purpose to improve respiratory endurance, muscle strength and confidence. shorten post-op recovery time. So these are the 8 things which we have to keep in mind post-op, that is post-operative phase treatment technique from our side, from physiotherapy side. Number one is patient education and explanation, care of incision, mechanical ventilation awareness, breathing exercises, huffing and coughing technique, mobility exercises, posture correction, graduated exercise program. So just do have a summary over the summary table. We'll move on for the next session of this video, that is physiotherapy in post-operative assessment after pulmonary surgery. So especially for the pulmonary surgery. Operative details. Number one, special instruction from the surgeon. Type of the procedure: lobectomy, pneumonectomy, wedge resection, etc. Precaution is to avoid side lying on operative side, because lobectomy is removal of one lobe. Pneumonectomy is a removal of one side of the lung. Wedge resection is any part is resected, that is, it's realigned, especially after pneumonectomy. So precaution, we have to be very cautious. Limitations on early mobilization and specific positions: presence of drains, chest tube or epidural catheters. Number two, respiratory status. Number one is operative details. Number two is respiratory status: breath sounds, auscultation over all lung fields, absent breath sound, pneumothorax or effusion, crackles, atelectasis or fluid overload, wheezes, bronchospasm. Compare bilateral for the symmetry. Cyanosis, assess the lip, nail beds, tongue, extremities. Peripheral or central, indicates hypoxia. Respiratory rate, normal, 12 to 20 breaths per minute. Tachypnea may indicate pain, infections or pulmonary compromise. Note shallow breathing due to pain or fatigue. 3. Vital signs: temperature elevated, infection. Monitor post anesthesia fever spike. 6. Pulse. Tachycardia can indicate pain, infection, hypovolemia or hypoxia. Number 7. Blood pressure, hypertension, fluid loss, bleeding. Hypertension, pain, stress. And next thing is about the chest and drainage monitoring. Pleural drain, intercostal drain, ICD, check for swinging. Normal fluctuation with respiration, loss of blockage or lung re-expansion. Bubbling may indicate air leak. Drain output. Color, serous, sanguous, purulent. Quantity, record hourly or daily volume. Sputum expectorated. Color, consistency, quantity, yellow-green, infection. Blood tinged. Commonly initiated post-op, monitor for increase. Assess the cough effectiveness and pain management. Analgesia. When was the last dose given? Type 4 or oral or epidural. Assess pain score 0 to 10. Timing of physiotherapy should ideally follow the analgesic administration. Chest wall observation. Chest wall movement. Observe for the bilateral expansion. Asymmetry may indicate collapse or splinting. Look for paradoxical breathing pattern. Reduced movement on operated side. Position of the patient: supine, semi-fowler, side lying. Encourage the upright position. Improve ventilation, perfusion ratio. Avoid lying on operative side, especially after pneumonectomy. Effort of breathing. Use of accessory muscle. Presence of nasal flaring, tracheal tug, retractions. Patients received breathlessness, perceived breathlessness. And 7 is investigation. Chest radiography. Review of the lung expansion X-ray. Position of drain. Presence of pneumothorax, effusion, consolidation. And atrial blood gas, ABG. pH parameters: pH normal range, indication. pH 7.35 to 7.45, acidosis or alkalosis. PaO2 80 to 100 mmHg, oxygenation. PaCO2 35 to 45, ventilation. Hyperventilation if it exceeds. HCO3 bicarbonate 22 to 26 MEq by L, metabolic compensation. SpO2 95 to 100%. If it's less than 90%, it's hypoxia. So this is the post-op summary table for pulmonary conditions. Surgical instruction, breath sound, cyanosis, respiratory rate, vitals, pleural drain output, sputum, analgesic timing, chest wall symmetry, position and breathing effort, ABG, or chest X-ray. Problem identification, post-operative pulmonary surgery patients. So, what are the problems that a physio can identify after a post-operative pulmonary patient? Pain, especially incisional or thoracic pain. What are the causes? Due to thoracotomy or sternotomy incision. Test tube placement. Muscular soreness due to positioning. Implications: inhibits deep breathing and coughing. Leads to shallow breathing. Increases the risk of atelectasis. Reduces participation in early mobility and exercises. Intercostal drains in situ. Causes: inserted to drain air or fluid from pleural cavity post surgery. Implications: restricts thoracic expansion. Patient may fear movement or deep breathing. Risk of drain dislodgement during therapy. May cause pain or discomfort, limiting mobility. Number 3. Decreased air entry on auscultation. Causes: pain related splinting, postoperative atelectasis, retained secretions, reduced diaphragmatic movements. Implications: reduced lung ventilation, risk of hypoxia, infection, and delayed recovery, compromised gas exchange. Number 4. Retained secretions. Causes: infective or painful coughing, shallow breathing pattern, weak expiratory effort, inability to mobilize mucus. Implications: risk of pneumonia, infection, bronchial obstruction, leads to further desaturation, requires assisted clearance, example huffing, percussion, postal drainage. Number 5. Decreased movement of the shoulder on affected side. Cause: post-operative guarding, incision pain, avoidance, behavior due to ICD or sutures. Implications: lead to shoulder stiffness or adhesive capsulitis. Poor thoracic mobility, inhibits upper limb function and daily activities. Number 6. Decreased mobility. Causes: pain, fear, fatigue, ICD limitations, weakness post-surgery or prolonged bed rest. Implications: risk of DVT, muscle deconditioning, slower recovery of lung function, delayed return to independence. Number 7. Poor posture. Cause: forward flexion to guard incision, reduced confidence to movement, ICU or supine positioning. Implications: lead to reduced lung expansion, inhibits effective breathing, affects spinal mechanics and overall alignment. So, this is the 7 main key important thing which are the problem considered to be identified as a physio. Number 1 is pain. 2 is intercostal drain, in situ drain. In situ drain is intercostal drain. Decreased air entry on auscultation, retained secretion, decreased movement of the shoulder, decreased mobility, poor posture. And the next thing is post-operative physiotherapy treatment technique. What are the treatment technique that a physio can perform after the patient have came from the surgery, whether it is tracheostomy or lobectomy or anything, whatever the surgery that a patient may undergo after the pulmonary problem, and what are the physiotherapy treatment that a physio can do. Number 1, deep breathing exercises, DBE. Deep breathing exercise technique. Patient in the semi-fowlers or supported sitting, that is in a relaxed position. Inhale slowly through the nose, expand the abdomen, hold for 2 to 3 seconds. Exhale slowly through the mouth. The purpose of deep breathing exercise is to prevent atelectasis, re-expand the collapsed alveoli, improve oxygenation. Number 2, segmental breathing exercise technique. Therapist places hands over the specific chest segment, example lower lobes or lateral ribs. Patient instructed to breathe into my hands. So, apply gentle resistance on exhalation. Purpose: to improve ventilation to underused lung segment. Restore thoracic expansion. Number 3, vibration. This technique is applied during expiration. Therapist places flat hand on the chest wall, applies fine Quick oscillatory movements combined with deep breathing. Purpose to mobilize the secretion towards central airway and aid expectoration. Number 4, percussion, clapping technique. Rhythmic clapping with a cupped hand over lung segments. Avoid bony areas, surgical side drains. Purpose is to loosen secretions for easier clearance. Stimulate cough reflex. Number 5, huffing and coughing technique. Deep breathe in, open mouth, short forceful, ha. Breathe like fogging a mirror. Coughing. Use splintered cough with pillow or over incision. Instruct patient to perform staged cough after a deep breath. Purpose, clear secretions without excessive strain. Minimize post-OP discomfort while maintaining airway clearance. Full range active assisted arm exercise, operated side. Example, shoulder flexion, abduction, rotation with assistance. Wall walking. Pulley if tolerated. A purpose is to prevent the shoulder stiffness, especially after thoracotomy, restore the thoracic cage mobility, improve circulation. Ankle and foot exercises. Exercise, ankle pump, circles, toe curls, heel slides. Purpose is to prevent DVT, deep vein thrombosis, enhance circulation, maintain lower limb mobility. Trunk mobility exercises. Exercises, side bends with breathing, trunk rotation and sitting or lying, reaches across midline. The purpose is to improve thoracic cage movement, mobilize spine, facilitate breathing. Posture correction. Number 9. Teach upright sitting, scapular retraction, chin tuck, avoid slouched or guarded posture. The purpose is to promote optimal lung expansion, prevent postural deformities, reduce post-OP muscle imbalances. Number 10. Positioning of the patient. Positions, upright, sitting or high fowlers. Better V by Q match. Side laying on non-operated side of pneumonectomy or the patient present. Purpose is to maximize the lung ventilation and drainage, reduce work of breathing, improve comfort and reduce discomfort. Number 11. IPPB, intermittent positive pressure breathing. Equipment used connected to a mouthpiece or a mask, provides positive pressure inhalation. Purpose is to increase lung expansion and deliver medications, prevent or reverse the atelectasis. Number 12. Inhalation therapy, nebulization with saline, bronchodilators or mucolytic. Steam inhalation if prescribed. Purpose is to loosen the thick secretions, reduce the bronchospasm, enhance airway clearance. So this is the 12 golden technique that a physiotherapist can perform after post-OP pulmonary patients or any cases, especially pulmonary cases. Deep breathing exercise, segmental breathing exercise, vibrations, percussions, huffing and coughing, full range of active assisted arm exercise, especially on the operated side, ankle and foot exercise for circulation, pumps, especially ankle pumps, circles, curls, heel slides, trunk mobility exercise, posture correction, positioning of the patient, IPPB, intermittent positive pressure breathing, inhalation therapy. So this is the summary table. Just you can have a look about this, and we can move to the next part of this video, next session of the video, that is physiotherapy after cardiac surgery. Pre-operative phase, assessment protocol. Number 1, medical history review. Surgical details, type of the cardiac surgery planned, example CABG, valve replacement, any surgical detail should be under medical history. Comorbidities, diabetes, hypertension, COPD, renal dysfunction, if there is any comorbidities. If the surgery is done, and what are the effects or what are the lateral thing that should happen, that can happen, that is called as comorbidities, or existing condition which may develop or which may get severe after surgery is called as comorbidities. Previous surgeries or hospitalization, current medications, anticoagulants, beta blockers, ACE inhibitors, etc. History of chest infection or exercise tolerance. Number 2, normal breathing pattern of the patient. Observe rate, rhythm, depth, use of accessory muscles. Look for the apical or diaphragmatic breathing, thoracoabdominal synchronization, signs of dyspnea or breathlessness. Number 3, pulse rate and rhythm. Check radial pulse for rate and regularity. Note tachycardia or bradycardia. Irregularities suggestive of arrhythmias. Pulse may be affected by beta blockers, anxiety or pain. Number 4, respiratory rate. Normal 12 to 20 breaths per minute. Increased RR may indicate anxiety, poor cardiovascular reserve. Pulmonary congestion. Number 5, blood pressure, BP. Note both systolic as well as diastolic valves. Pre-OP hypertension or hypotension may be documented. Consider postural changes if orthostatic hypotension is suspected. Number 6, thoracic mobility assessment. Manual palpation of the chest wall during breathing. Compare symmetry and amplitude of the thoracic expansion, upper, middle, and lower zones. Note any pain-related splinting, reduced movement due to anxiety or deconditioning. This is 6th thoracic mobility assessment. And 7th assessment is about the posture. Forward head posture, rounded shoulders, kyphosis, scoliosis, lordosis, anything. Posture, poor posture can comprise ventilation mechanics. Especially when we are talking about the posture, in cardiopulmonary part, we'll be discussing on the thoracic. Because the thoracic cage or the rib cage is the main part of ventilation. Inside is the lung. Affects breathing and exercise post-surgery. 8, exercise tolerance assessment. Used a 6-minute walk test, modified Bogue dyspnea scale, talk test, ability to speak in full sentence during activity, observe the fatigue level, heart rate response, breathlessness or angina, helps in designing greater activity plan. Predicting post-OP mobility progression. So these are the 8 parameters or the 8 considerations of the assessment protocol that a physios can be taken notes for the cardiac surgery, after cardiac, pre-operative. So in after cardiac surgery, we are considering pre-operative in the session. Number 1, previous medical history. In their surgical detail, comorbidity, previous surgeries, current medication, history of chest infection. And number 2 is normal breathing pattern of the patient. Number 3, pulse rate and rhythm. Number 4, respiratory rate. Number 5, blood pressure. Number 6, thoracic mobility assessment. Number 7, posture. Number 8, exercise tolerance assessment. In the next, so this is the summary table. Just you can have a look about this. If you want to take notes, please do pause this video. As I have mentioned earlier, this was the lengthy video. So have some snack and keep you hydrated. So physios. Next one is pre-operative physiotherapy in cardiac surgery. Or what are the identified problems that a physio can identify as excess secretion. So the clinical impact is the risk of post-OP atelectasis, pneumonia, may impair ventilation. Number 2, decreased thoracic mobility leads to shallow breathing, poor lung expansion post-OP. Number 3 is defective posture, reduces chest wall movement, affects breathing mechanics. Number 4, decreased exercise tolerance, increases risk of delayed mobilization, DVT, fatigue, post-OP complications. Demonstration of treatment technique, pre-operative. Patient education and orientation. Purpose is to reduce the anxiety and improve cooperation of the post-OP care from the patient side. Explain about the type of surgery planned, with either it's a CABG or valve replacement, incision site and possible discomfort, what can happen. ICU environment and devices to expect it. If it's endotracheal tube na, for mechanical ventilation it's placed. If the central line for drug and fluid administration, it is placed. For nasogastric tube, gastric drainage, it is placed. ECG leads for monitoring the heartbeat continuously. Chest drain for draining the fluids of the post-surgery care or any secretions. Peripheral IV lines for medications. Temperature probe for core temperature. So, executive benefits, mental prepare. The patient can prepare themselves mentally and reduces the fear, anxiety, and resistance to post-OP care. If we have educated the patient earlierly, the patient will cooperate later. Number 2, breathing exercise. A, diaphragmatic breathing. Place one hand over the abdomen. Inhale deeply through the nose. Feel belly rise. Exhale through pursed lip slowly. B, segmental expansion. Therapist or the patient places hand on lower ribs or side. Encourage the expansion of specific lung areas. Benefit is to improve lung expansion, reduces the atelectasis risk. Number 3. Splinting the incision. Technique: place a rolled towel or pillow over the chest mid-sternum. Instruct patient to press against it while coughing or huffing. Benefit: reduces pain or improve effectiveness of cough, protects surgical site. Huffing or coughing techniques. Huffing is post-expiratory technique. Take a medium breath, open mouth and exhale forcefully with a ha-ha sound. Supported coughing: inhale deeply, splint incision, produce 1 to 2 strong cough. Benefit is to clear the secretion while minimizing the incision pain. Number 5. Posture correction. Teach upright sitting posture with a scapular retraction. Avoid slouching or guarding posture. Benefit: optimizes chest expansion, prevent musculoskeletal complications. Number 6. Range of motion exercise to trunk and shoulders, especially for the thoracic trunk. Exercise: shoulder elevation, abduction, circles, trunk side bends, rotation gentle. Benefits: prevent stiffness post sternotomy, improves thoracic mobility. Number 7. Ankle and foot active exercises. Exercises are the ankle pumps, circles, toe curls, heel lifts, as we have already discussed in the pulmonary part. The same exact. The benefit is to improve circulation, prevent DVT, keep lower limbs active. So this is the summary table. Number 1, patient education. Number 2, breathing technique. Number 3, splinting. Number 4, coughing and huffing. 5, posture correction. 6, shoulder and trunk ROM. Ankle foot exercises to improve the limb circulation, maintain to prevent DVT. So this is pre-operative care, and in this session we are going to discuss about the post-operative care. Post-operative care parameters. Number 1, special instruction. Note from the surgeon's instruction, which we have to follow as physios. We have to follow, and it's good to keep an eye on that notes. Movement restriction: if we have to avoid the movement, example, avoid shoulder abduction in 90 degree greater than 90. Drain management, use of sternal precautions we have to follow. Type of incision: usually mid-line sternotomy, as is for the wound condition. If it's dry, clean, sign of infection, so the type of incision and also the wound condition should be taken care. Location and size. Pain during movement or coughing. Number 3, vital sign: blood pressure, pulse rate, respiratory rate, color of the skin and lip, temperature, time of the last analgesic dose given, drain observation, ECG monitoring, chest X-ray to prevent the chest X-ray to examine for the atelectasis, pleural effusion, pulmonary congestion, pneumothorax if present. Number 7, atrial blood gas (ABG), hypoxemia, hypercapnia, acid-base balance. What is hypoxemia? Decreased PaO2. Hypercapnia: increased PaCO2. Acid-base balance, pH. So this is the identification of the common problems post-OP by the physio. Pain, decreased air entry, retained secretions, reduced arm and leg movements, decreased mobility. So what was considered to be as the assessment part? Clinical example of physio notes is subjective. Patient complains of moderate incisional pain, 5 by 10, feels weak, unable to cough properly. And objective, RR is 26 BPM and pulse is 96 BPM. BP is 110 by 68 mmHg. Assessment: SOAP format, subjective, objective, assessment and plan. So in objective, shallow chest expansion, reduced air entry basis, weak cough, chest drain in situ, reduced shoulder ROM on operated side. And assessment part will be impaired airway clearance, post-OP pain, reduced thoracic mobility, early signs of atelectasis, deconditioned lower limbs. And the plan is to breathing exercise, in situ spirometry, splinter, cough and huffing techniques, active range of motion to upper and lower limbs, bed mobility and sitting over edge. And also educate on posture and movement. Post-operative physiotherapy treatment, it's a demonstrative guide. Number 1, breathing exercise, as we have mentioned. Number 2, suctioning, active-assisted, graduated exercise from day 1 to day 2. Day-wise program is very important. Day 1 breathing, bed mobility, ankle pumps, assistive. Day 2 sitting on bed edge, support marching in place, short standing. That is sitting. Day 3 is ambulation with a walker, help or posture correction, shoulder range of motion. Day 4 to 5 is independent walking, short distance, a stair climb if stable, if possible, functional training. So the goal of the graduated program is to prevent DVT, enhance pulmonary function, improve circulation and limb strength, promote independent mobility. Precaution during treatment is vital. Check for the vital, monitor for the vital before and after the session. And abduction, shoulder of it should not exceed 90 degree in early stages post sternotomy. Use sternal precautions, pushing, pulling with arms. No. Avoid fatigue or breathlessness. So in the next session, it's a physiotherapy and general treatment. As we have already learned, if you want to take notes, as usual, you can take notes. You can pause the video and take the notes. That's it. The repeated same will be coming for mostly it will be coming. That's it. Hope you guys have learned something new in this video. Keep learning. Stay tuned. Please do leave a comment for any doubt and related queries. Happy learning.